You guys are going to stand up here, right? Or you're going to sit like that? Okay.
Whatever.
Okay. Got it. All right. Is that it? Okay, no, that's gonna make it more complicated. I'm sorry, you gotta come here. Please don't make it complicated. Sure. I mean,
more plates, but we'll go ahead and get started. So I'm going to pass the mic to our two MS4s that are here that are going to be emceeing this, Colin and Ope. So I'm going to let them introduce themselves first, and then they're going to turn it over to the panelist. Thanks.
Hi, everybody. My name is Colin. I'm one of the MS4s with the Global Health Selective today. I just a little bit about myself. I'm going into emergency medicine. So if any of you guys have any questions about that or anything else MS1 related, happy to answer any questions.
And hi, everyone. My name is Opa Karale, and I am an MS4 as well. That's currently taking my leave of absence to do my MBA at Anderson. I will be going into anesthesiology next year. So if you have any questions on that, you can also ask me. I'm also really interested in artificial intelligence and global health and technology. All righty.
Opa is much cooler than I am. I'm going to go ahead and introduce our four panelists here today. Thank you guys so much for coming out and taking time out of the middle of your day to do this. First on the left, we have Dr. Kiran Masoon now. Name change. Currently, she's the assistant clinical professor of pediatrics in GenPeds. Or MedPeds, I'm sorry. And then she's also GenPeds. Oh, excuse me. And then she is a partner lead. She works with partner leads in Peru, where she has merged the Department of Pediatrics at the Hospital Regional de Loreto and UCLA. Currently, she is the co-director of the Global Health Track for UCLA Peds Residency and the director of the pediatric program for Seed Global Health, a nonprofit supporting education and the training of local healthcare workers in East Africa, including Uganda and Tanzania. Secondly, we have Dr. Steve Commons. Currently, he is the Associate Director at Luskin for Global Health Affairs and the Director of the International Practice Pathway. Previously, in the 1980s, he was the Director of Development Institute at UCLA African Studies, and in the 1990s, he was the Director of Policy and Planning at World Vision. From 1999 to 2005, he also worked as a senior human development specialist. And currently, as mentioned, he's the associate director at Luskin. I'll have Appa.
We also have Dr. Cecily Gallup, and she is the associate clinical professor of internal medicine pediatrics at UCLA. She's conducted research in Niger, South Africa, Rwanda, Malawi, and Haiti. She's been a part of Physicians for Human Rights and she's performed medical evaluations of survivors of torture and persecution. She does a lot of work with the Los Angeles Human Rights Initiative as a director. She's also a part of Alliance for International Medical Action, ALIMA, a Senegal-based humanitarian medical organization that operates in conflict zones in West and Central Africa. And then lastly, we have Dr. Shant, who is currently a pediatric surgical faculty. And he's a global health researcher on health systems strengthening and development of QI initiatives in post-Soviet nations.
So the way that we kind of want to do this is like very conversational. I know that we have a panel here, so we want to make sure that you guys are able to get in as many questions as possible. If you guys want to start with questions, or we can as well, but I guess like just to break the ice, Dr. Masoon, I was wondering if you could tell us about Seed Global Health and what's unique about it.
Yes. Hi, everyone. I'm Karen Masood. Like Colin mentioned, part of my global health role has been working with a nonprofit organization called Seed Global Health, which is a nonprofit that is focused on training the next generations of physicians, midwives, and nurses in lower resource settings. Currently, Seed works in 4 different countries in East and now also West Africa, Uganda, Malawi, Zambia, and Sierra Leone. We used to work in Tanzania as well, as Colin mentioned, and I spent a couple years living in Uganda and Tanzania while I was working with them. I started working with them as a volunteer educator, which is something that is open to all, graduates who are board eligible or board certified. So essentially after you finish your residency, and spent a year working at a newly established medical school in a rural part of northern Uganda, teaching pediatrics in the clinical setting. And then took on a role to really help develop the organization from a system standpoint and helped really further our partnerships across multiple medical and nursing schools on the continent. The thing that's very unique about Seed is that we work within the public education and health systems, which is different than a lot of other NGOs or non-governmental organizations or nonprofits that you'll see. We really focus on empowering champions within the system to become nurse and physician leaders. To date, I can give you a few numbers just to help share some of the impact that we've had. We've placed a little over 200 physician and nurse educators in our 10-year history. They all serve for 1 year or more, and we've trained really, I want to say about 34,000 healthcare workers is, I think, the most recent estimate. So really working within the health system, the educational space within countries to really build the infrastructure and capacity there.
What would you say were some of the challenges working in a completely different healthcare system for nearly 2 years?
I mean, there are the obvious challenges that you guys could, foresee, difference in resources, different cultural practices and miscommunications that can happen. I think the biggest eye-opening thing is to really understand how the pace of change can be quite slow when you're working within the public sector, but how valuable that change can be once it happens. There are a lot of organizations that are trying to show, the value and the impact of what they're doing, and there are really easy fixes or easy outcomes that you can measure, like how many babies did you vaccinate, as one example, but really working to create generations of physicians, nurses, and midwives. That's sort of a long game, right? You have to wait for people to get trained, potentially go through residency, find placements. So it is much harder to show that impact, and you're really thinking about the long range rather than the short range. But working within the public sector, you can really see the impact that you're going to have on the future of that country. So it's really valuable and meaningful from that standpoint.
Thank you so much for the introduction to the organization and just going so deeply into it. Moving on, Dr. Commons, you've worked with many different types of organizations, including the World Bank, USAID, World Vision, and Save the Children. How would you assess the type of impact that each organization has and what's like unique about it and why?
Is this a trick question?
It might be.
I think, first of all, there's a difference between organizations that have a sole focus on health, whether it's World Health Organization or Partners in Health or medical teams international, and organizations that are multifaceted, that have 10, 15, 20 different groups. Because I think in the bigger organizations, the weakness is that there isn't the sole focus on health. But the strength is it can be maybe, if you cooperate, you link up with your water and sanitation people, you link up with the education team. And for example, I would say to me, some of the most productive experiences were several joined up opportunities in the early 2000s. There was a huge initiative around school health with the World Bank, UNICEF, and World Health Organization, particularly focusing on separate latrines for boys and girls, functioning latrines, hand washing, and that later on began to bring in the World Food Program and others so that you then had school feeding programs. Because just as in the United States, several states, including Minnesota, I believe, now mandate that all children can have free meals at breakfast and lunch. I mean, what a shocking, socialist, horrible thing to do. They might actually learn and not, sit there starving by 2 o'clock, or in my case, 10 o'clock. I think that kind of joined up approach was good. The other thing is working across domains. So the World Bank, a funder, Multilateral Development Bank, World Health Organization, a technical organization, they in turn often then worked with a group like Save the Children or medical teams or World Vision or others in the program implementation. So I think it's really which groups have which responsibility, but how are they willing to share the space? I mean, you made a really good point about the fact that the work of preparing health workers in the public sector doesn't get big visibility. You don't have quick wins, but it's the foundational work. And the same way, unfortunately, less with the World Bank, a bit with government agencies like USAID, because they have to make Congress happy. And unfortunately, very big, even with the best NGOs, you have to kind of show we're saving lives, we're making things great. That may not be the best way to spend the money. And a lot of the work I did on sort of health in post-conflict countries, the tension was between saving lives and restoring services. And how do you do both? Because you can't tell people who have no health care, well, in 20 years, guys, it's going to be great. But on the other hand, if you just keep doing the same kind of emergency healthcare, you're never going to have a system that functions. So, I think the story you shared is really important to understand that the foundational aspects are critical.
I also want to make sure we open the floor for anyone who wants to ask questions. I know there's like over 10 years of experience in Partners in Health, and a variety of people have also public and global health experience. So just making sure anyone who has questions is welcome to ask. Okay. So Dr. Commons, if you could choose one project that was very valuable to you, which would you choose?
It's actually easy. The Multi-Donor Trust Fund for Health in Liberia, because it rebuilt the health system in Liberia. It focused on Liberian capacity. The head of Liberian Health, my old friend Walter Gwenegali, was very specific. So after the humanitarian flow, he basically pulled all the NGOs together and said, you can stay and provide technical support at the clinics, But every single clinic is going to be managed by Liberians, by Liberian nurses, by Liberian physician assistants. And the other thing he did was he had Price Waterhouse monitor the money. So nobody ever complained about corruption. Nobody said, where'd the money go? And I think I mentioned this at base camp. Unfortunately, because of Ebola, a lot of that was deeply damaged because, just as we saw that the US and UK and others couldn't cope with COVID, the idea Liberia or Sierra Leone could cope with Ebola wasn't going to happen. But it was a great project because you would go out to rural clinics and they were all run by Liberians, and maybe MSF or World Vision or Mercy Corps had a technical support person, but it was a Liberian-owned program.
Thank you, Dr. Collins. We'll move on to Dr. Gallup here. Dr. Gallup. Dr. Gallup, can you tell us about your NGO, Alima, and how you got connected with the organization?
Yeah, sure. And I'm actually glad that I'm speaking after Dr. Commons because there's just a lot of sort of parallels to what you just kind of discussed. So yes, I've been working with Alima since probably 2016-ish. And basically, as I think Ope mentioned, this is an NGO which works mostly in Central and West Africa in various different countries, 14 to be exact right now. Budget's around 80 million a year. And this organization started back in 2009, was started by a few people who used to work at MSF who were sort of disenchanted with that model and wanted to start something new, which was more innovative, research-based, evidence-based humanitarian intervention. And so that's what they ended up doing. So today there are over 30 different research projects that have been conducted, many of which actually have been published. And so a lot of the medical interventions that Alima is involved in these various different countries are purely evidence-based. And so I'll give you a couple examples of that in a second. There are three pillars. One is medical intervention. The other is research and innovation. And then the third is partnerships. And so this is really where I think Alima stands out. And I think there are a lot of other NGOs that are becoming more like this, but Alima is really like a platform. And 98% of those who work for Alima are from the countries where Alima works. And so that's a really, really important thing to Steve's comment about, Liberian owned, et cetera. It's the same thing with Alima. Most of the people who work for this organization are from those countries. Not so much at the sort of upper level there, it's only 85%, but I still think that's pretty good. That's very different from like MSF, which is very lopsided in the other direction. And so this is one of the reasons why I got involved with Alima. I was asked to be a member of the board back in 2015, 2016. So I actually work on the board. I'm the board president now for the USA board. There are two boards, and this is important as well. The other board, which is the main one, is based in Dakar, Senegal, where the main headquarters of this organization are. So it's not US based, it's not based in Europe, although there is a small headquarters in Paris. Most of the main board is African. Important as well, because that's not always the case. So my job as USA board president is really to bring awareness to the organization in the US, get donors involved and interested, and also work on grants. And so I'm also on the program committee. And so that my job on the program committee is actually to review grants. And these are all sort of, from foundations, et cetera, within the US. So it's actually kind of interesting because most of my work internationally was clinical, right? Or a little bit of research. And so I've never actually, studied an organization from this perspective. And I think it's really important to do so because you see all of the faults, and all the good parts. So I've really learned a lot from being on the board. What else can I tell you? So I did want to give you an example of why I think Alima is kind of unique in this sort of NGO, sort of humanitarian assistance sphere. And that's the research part of it. So I brought this little fancy thing here. I don't know, have you all seen this, MUAC? So it's basically a screening tool used to screen children for malnutrition. And so you just put it like sort of mid-upper arms, the mid-upper arm circumference. That's what MUAC means. So what Alima did is they conducted several large scales. Is this even working? Large scale studies to see if mothers or other caregivers, but they started with mothers, could actually screen their own children for malnutrition. And they started in Niger. They also had a study in Burkina Faso. And the study showed that yes, mothers can do so just as well, if not better than healthcare workers. So as a result, they've trained millions of mothers and other caregivers, not just mothers, to do this at home. And UNICEF and other large organizations have actually adopted this practice. And so why is this important? It does sort of empower caregivers, first off. Secondly, it actually leads to earlier detection of malnutrition. Thirdly, it decreases inpatient hospitalization for malnutrition. Fourthly, it's probably cost effective. There's studies that are sort of looking at that as well. So I just want to sort of give that as one of the examples of a large scale study that has been adopted by a lot of other organizations and NGOs. And that's pretty cool, I think. So I don't want to go on, but I could say many more things.
Love it when you.
Yeah, sure.
Thank you. I wanted to know if you could kind of describe to us what's the difference between the work of an NGO versus like a governmental organization like USAID that's bilateral.
Yeah. So, I think that's a huge question. And I think that, people like you might be better sort of equipped to answer that. But what I can say, I think one of the major differences, and this leads to sort of good things and bad things, is the independence of an NGO, right? So there are no agreements. They're not really supposed to be affiliated with any governments, although that's questionable. So what does that mean? So in terms of, sort of positive impact of independence is that they can really sort of serve as a voice or give representation to those who might not have a voice or representation otherwise. And so what do I mean by that? Not only those that it serves, but also those who work for the organization. So that's one thing. And then in doing so, they can also advocate for those who they're serving and bear witness. And so these are things that like MSF has done very, very well, right? Bearing witness to things that are happening that other people may not know because they're not on the ground. They don't have a long-term presence in some of these conflict zones, et cetera. Alima does this as well, for example, with oxygen inequities. So as you all know, there are many places in Africa where there is not enough oxygen, right? We saw this during COVID, but we have seen this way before COVID. So Alima right now has a campaign related to oxygen scarcity. So things like this, I think they're very well equipped to sort of shed light on. The way that, being independent may have negative impacts is that there's no accountability, right? So, I mean, a lot of these larger organizations do show impact, et cetera, for their donors, but a lot of the small NGOs do not. So that's a big problem. And I mean, I can go on and on and on, but I think I'll stop right now because I feel like I want other people to speak a little bit, but yeah. Any questions from anyone?
We'll make our last one. Hopefully.
Being that you were the organization based in critical speaking issues, how have been able to that both on the keyboard side, I guess, the higher up side, but also on the ground.
Yeah.
There's just a difference there.
Yeah. Yeah. So I actually happen to be French, but that's an aside. So I'm on the board, on the USA board. So as I mentioned, I'm not one of the people who works like for Alima. I have been to Niger, for example, and toured some of the projects there. And I was with a bunch of Nigerian physicians, all of whom speak French and English. So that's how I communicated with them. I didn't do any direct patient care. I did get involved in some trainings. And so those trainings were all with nurses and other healthcare providers. We were doing like newborn resuscitation, et cetera. And I spoke French during that whole time because all of those individuals spoke French because they had learned French in school. And then when I did speak to the patients, there was usually somebody who could translate if they didn't speak French and spoke a different language. But you're right, like it's not always obvious. Now, the good thing is, as I mentioned, most of the people who work for Alima, are from the countries where the projects are being implemented, so they don't have any issues with communication.
For those in the panel that have more practical experience with a country that may have been culturally very variant from what they grew up with, can you speak a little bit to like the value of the cultural version of these things, specifically?
I can help answer that question. So, yeah, I think for me, spending that time in the clinical setting was really invaluable. I had, during medical school and my residency done short, 1 month, 2 month stints. But it was really that year-long immersion when I was in Uganda that gave me a much more insight, not into just the culture, but really the healthcare system. And I think because the way you're perceived by the local population really can change. A lot of places where there's been international involvement for many, many decades, there's like expat fatigue. There are always new people coming in, coming out. So you don't necessarily buy into the local population's trust if you're there for a short period of time. And so even early in my experience, when I shared with someone that I was going to be there for a year, it really opened up different doors, different conversations into understanding the culture that I don't think I would have had access to if I were there for a short period of time. Of course, those short experiences are important for you to sort of figure out, do you like this? Is this, what kind of experience do you want? But like being there on the ground for a long period of time can really help you understand a setting in a lot more depth and also give you clarity about how you want to be involved in global health in the future.
This is another question for the panelists who have joined these or abroad. I'm wondering what kind of differences you notice between our medical training here and medical training here there.
Let me just re-summarize the question. The difference in the clinical training of providers?
Yeah.
Between. So I can speak on behalf of the experience in Armenia. The education, the training, the culture and approach to patients is very, very different. Starting from just the curriculum and the foundations of the medical school being straight out of high school rather than having an undergraduate coursework beforehand, to the way that the clinical specializations are divided or subdivided. For example, and that's not unique only to Armenia or to low to middle income countries, even between the United States and Europe. In my field of pediatric surgery, there is some overlap with urology here, and there is a lot more, for example, in Europe. So all of these very much factor into how I have been involved in clinical work in Armenia, which has been a very small portion of what I do in Armenia. But maybe to circle back with that question, does that answer the question, or do you want more specifics or details or?
Yeah.
Okay, all right. I would come back to the question before, and I would say that this is part of sort of not only the cultural sensitivity and the cultural humility, but also knowledge of the local landscape is extremely important. In fact, maybe I'll take the liberty of giving a stern sort of surgical comment on that. Lack of all of that knowledge is actually dangerous and harmful. And so thanks for bringing up that question, and thanks for everyone for having that in the back of our minds, that whatever we do, make sure that we're not causing, the what we learn on the first day of medical school is do no harm, right? So whatever we're doing should not be causing any harm.
I guess to like build off of that, one thing we forgot to mention is you work with the Ministry of Health over in Armenia. And I guess, can you share some of the challenges as well as some of the advantages with working within a Ministry of Health in order to improve it?
No challenges. It's it's a different country, different culture. It's working for government, which is challenging anywhere in the world. It's working for a former Soviet government with an incredible amount of bureaucracy, inefficiencies, that would go along with that, which may not actually be unique to the former Soviet space, but there's certainly some peculiarities with regards to the culture and the history and the legacy that the Soviet Union left in terms of specialization or other factors that sort of compound the work. So it's an incredibly challenging landscape, but I think the key would be to have, I guess my approach has been over the past 2 years when I've been most intensively embedded within the Ministry of Health, spending the past 2 years living in Armenia, is also setting realistic expectations and having sort of the mindset to be compatible with being in an environment like that. So 2 years ago when we moved out there, there was a little bit of, wow, I'm going to go there. I have 2 years and I'm going to change a lot of things. But largely my mindset was, how can I go there, be embedded, learn a lot, and try to just move the needle 1 degree, because that 1 degree move 5, 10, 15 years down the line will actually lead to the course of healthcare or the system strengthening actually being a lot more different than what it is right now. So I think part of being able to survive in an environment like that, whether it's Armenia or elsewhere, is having an appropriate level of expectation, being ambitious, not sort of being complacent, but also realizing that sometimes the impact that one can have is not something that could be measured in terms of, I don't know, whether it's number of quote unquote lives saved or surgeries done or this and that. But for me, for example, one of the things that I wouldn't say proud, but one of the things that I think was the highlight of the 2 years there is doing something that's not at all related to my clinical background. Is when I went to the Ministry of Health, there was nothing like having staff meetings at the ministry. So everyone worked in silos. Everyone went and reported directly to the minister and then went back to their offices. All of the office rooms were closed. The finance people didn't speak to the quality people, didn't speak to the pharmacy people and whatnot. And one of the things that I, along with a colleague of mine who actually has a legal background, who is also embedded within the Ministry of Health, it was to establish this culture of having staff meetings. And for the first time, on a table sat all of the deputy ministers with the minister and this group of advisors. And we started to think about things on a much more comprehensive, if we can call it multidisciplinary facet. And again, it's not that we can say that staff meeting has now resulted in, I don't know, Armenia implementing universal health coverage. But I think that on the path towards Armenia's desire to implementing universal health coverage, we stand a better chance of being more effective at doing that because of these process things that we've been able to implement.
Thank you so much for sharing. I've noticed amongst our doctors, we've have a commonality in pediatrics. I'm curious, how does that specialty choice may have an easier impact in health policy, health finance, all these things in terms of like moving the needle in global health and public health?
We're both real pediatricians. I mean, I can start to tackle that question. I think one thing from a population standpoint that is important to note, which is different from our demographics in the US, is that children make up a much larger percentage of the population in lower and middle income countries. In some countries, up to 50 to 60% of the population is under the age of, 15 to 18, depending on how you want to define adult. So the need for pediatric care is much higher. But also when we're thinking about, making change and sort of these longer range goals, you're really thinking about future generations. And so obviously pediatrics sort of lends itself to that. Anything more?
Yes, also say that, yes, there are a lot of children and they're very, very. So, I mean, one of the reasons I'm a, so I joke, I am a pediatrician. But one of the reasons I chose that was the pediatrics part and global health. So most of the clinical work that I've done has been in pediatrics. I was also gonna say it's a little more simple, but because I am on the board and a lot of it is fundraising, I think that pediatrics, your office of global health are considered money for, along with things like Ebola, et cetera, which is another thing that does. So maybe not now.
You just picked up what I said in our discussion yesterday, that in terms of the politics today, it's easier to get the US Congress or Canadian Parliament or UK Parliament, even more conservative members to fund the church. It was many other things.
So it's a interesting observation. I haven't really thought about it. So I would say a couple of things. First of all, that while I'm a pediatric surgeon, I also am very comfortable with taking off that pediatric surgeon hat when I board the plane at LAX and then go in with more of the public health hat when I'm in Armenia. To the point, even to the level of I was actually involved with and co-led the Armenia's primary care strengthening task force. And so it's not necessarily that your clinical specialization or your clinical interest has to absolutely align with your global health interests. But I think there's value in actually merging the two. So I think the pediatric components of my practice here, the patients that you develop while you deal with children, the holistic approach to not only taking care of or considering the patient, the child, but also the family dynamics applies to every single meeting or every single issue that has sort of come up when I've been at the Ministry of Health, right? There is a question there. What do we do with, I don't know, the emergency ambulance issue in Armenia, right? But then you realize it's not just an ambulance issue. There's the ambulance personnel issues. Like, so to me, it's much like taking care of the child, which is also a larger taking care of the family. And the same thing with regards to my surgical background, right? So being comfortable with being in very stressful situations has proved to be very helpful when I've been at the ministry. So I think it's a very beautiful actually merging of the clinical knowledge background training with some of the public health exposure and experiences that I've had, and one very much complements the other. Like I really enjoy and I'm very passionate about being in the operating room with a small baby, but then having a really long day of having meaningless meetings from 7 a.m. to 10 p.m.
The other little piece I'll add in case this is making it seem like you need to do primary care or be in a really broad field to be in global health, that's not at all the case. I think, some people think about doing family medicine or med peds with that in mind, thinking like that's the only way to really do global health. And really any specialty, subspecialty that you can think of, there is a need. And so not confining or restricting sort of your interests to align with what you think might be needed in global health. Global health is health, right? No matter what you choose in healthcare, you can find a way to make an impact globally. I can give an example. I'm working right now with a small group of interventional radiologists who are going to do some trainings for our partner site in Iquitos, Peru. And you would think that's like, a subspecialty doesn't necessarily have a lot of broad applicability, but they've been doing work in all different settings across the world, and we're really excited to get them involved in Iquitos. So just to throw that out there in case that it just so happens that there are 3, pediatricians or pediatric specialists here, but that's not really at all necessary for you to get involved.
Thanks, everybody. Sorry, Dr. Khan. Oh, perfect. I'm sorry.
Yeah, so I think generally people think
about global health, I feel like it's always one-sided, where it's like we have something to bring and teach this country that we're working in. I'm wondering, and on the flip side, what have you learned from your work in other countries that you kind of brought back here, I guess, in your work here in the US?
I can start with a really basic example that I think was really eye-opening for me when I was a resident. And that was my first experience actually going to Uganda when I was a third-year pediatric resident. I remember in my continuity clinic here at UCLA, I would get a lot of families where moms were really anxious or nervous about their kids being anemic. And I never really understood, like, what is the big deal? This is something that's easily treatable, or, and we don't really see severe anemia very commonly here. And then when I spent a month during my third year in Uganda, seeing all of these kids who had severe malaria and they had hemoglobins of 3 and 4 and 5. And, it sort of sunk in that, when I'm seeing families that have maybe come from these contexts where there is a severe version of something that we don't see often here, that's sort of where that anxiety and that concern stems from. And so really understanding sort of the cultural and contextual and underpinnings of a parental concern can be helpful in really addressing the root of their concern.
So not being the medical person, I have, a very different angle, which is that for a long time, I've said I've learned much more about effective accountability in services from other countries than the United States, because in many ways we think of these as being professionalized. Now, unfortunately, in the last few years, both in the health and education sphere, has become so politicized that if I say I really want wide community participation, then it sounds like I'm going to ban every book in the Santa Monica Library. That's not what I mean. What I mean is that there are very strong citizen movements to say, where is our money going? How is it being spent? What's the outcome? How do our health systems work? Why are we financing this type of healthcare, not that type of healthcare? Now, it's at a very basic level, but I'll give you an example. In the 1980s into the 1990s, there were surveys done of financial flows in Uganda from the central government to the schools. And they found out that 13 cents on the dollar reached the school. Now, in World Bank terms, that used to be called leakage because no one ever said corruption. So I guess little pennies were falling out of the pipes. The government actually made that a cause célèbre and put it on the radio and put it in newspapers. So people would show up and say to the school principal, we understand there's budget for toilets. Why aren't they being built? And within a decade, over 85 cents on the dollar was reaching the school. I think it's, I don't say dangerous, but you have to be careful in health because, let's say, compared to education, I followed a lot of programs where parents monitored the schools to see if the children were learning math and reading and writing. That's pretty easy to monitor. It's much more difficult to sit and monitor a health provider who's making a diagnosis. So I think it's very different. The term economists use, the asymmetry of information, is much higher in health. So how you get people deeply engaged in basic services, education, health, and other fields takes some care, but I think it's really, really important, partly because certainly in the United States, what people have critically said, the medicalization of health, so you don't think about your diet, you don't think about exercise, you don't think about your mental well-being, you don't think about how many hours you're actually at work. Now that's changing, but that's also a way of getting people engaged in their own health and well-being. You can have mine.
So that's a good question, and I've been thinking about it, as both of you have been speaking. So I would say, I mean, there are many things I've learned, very like medical things, like most of what I've learned about various different types of disease processes has been, by colleagues in the various countries I've worked in. But what I would say even more importantly is the sense of community and how that plays into every individual's health, which quite frankly, I don't think exists here for the most part, at least in my practice. And what I mean by that is, I can use my experience in Niger, for example. All of those we work with and Alima works with in Niger, they're all working with local NGOs, and they're all part of the communities, and they're healthcare workers, and they're all these people who all know each other and take care of each other. And these are things that I think, I was quite struck by. Very different from other models of NGOs like MSF, which I also worked with MSF for a number of only months when I was much younger, but very different model, right? Where it was just expats involved and really no one else at that point. This is like, 15 years ago. The other sort of model I saw this sort of play out and was in Haiti. I was working after the earthquake in 2010. All of you were very young at that point. And I was in a field hospital. And again, the community in this hospital was really integral in the health of all the individuals, right? You'd have someone who was nominated as kind of the main healthcare worker in this field hospital. It was outside, just tents. He would go and find people he was worried about and bring them to the physicians who were working in the hospital. And so, I've learned so much from this, and it's really incredible to see. So that's something that I've taken away from a lot of the different experiences I've had.
I can answer too, unless there are more questions. Not to. So there's a practical answer, and then there's my philosophical answer to this question. Practically is, I mean, it's just all of my experiences have been incredibly educational, and I think everyone that's involved in global health will answer the same way, that we come out much more whole, much more like we've received more than we've given. And that goes down to even my, in my clinical practice here has changed because of many of the things that I've seen my surgical colleagues see or do in Armenia and beyond. So there's very much a lot to be also gained, or the whole like global to local and all this kind of stuff. But here's my philosophical answer. I don't like and reject the hypothesis that global health or engagement in global health, the currency of that should be learning and or teaching and helping, and then receiving and learning from that. To me, in my mind doesn't work that way. I don't think about it that way. I think about it more. In fact, I have once a mentor that said that if you can take out the word help from your vocabulary and your mindset, you'll actually be a lot better person. And I try to never use the word help, because none of this for me is about helping. There are challenges, there are issues. For example, in Armenia, there's various issues with regards to the healthcare system. And I'm part of the team that's trying to address those challenges. Along that way, of course, I'm learning. Along that way, hopefully, I'm contributing to that. But that's it. And it's very similar to my colleague, at least the way I see it, to my colleagues that are in the lab here, looking at neuroblastoma. It's a challenge in kids. It's a tumor that affects many children around the world. They are working towards addressing that challenge. Nobody is thinking about, how much they've contributed to it and how much they've learned along the way. We're all just part of the team addressing various challenges, various issues in our world. Ours happen to be in global health and in other countries, but yeah, so I don't know if that helps answer the question, but I think it's useful to put oneself in a mindset that diminishes the whole like ratio of how much have I given, how much have I received, and all that stuff.
Following off of that comment, for those of us who are in the pathway and know that we'll be spending first and third year, or those who maybe have to go through elective and things like that, how do you, or what advice do you have, or how do you think you should sort of approach expectations going into that, or how we should, I guess, use that experience, given, the limited amount of time, where we are in our careers, our capacity to do this exchange, kind of based on that, I guess what philosophical framework, I think we should sort of view what our potential experience would be.
I'll start. I think being open and flexible to what opportunities may arise is really important. I've seen, some students approach their discovery year project with a lot of ideas in mind, which can be helpful in terms of brainstorming, but often when you're too set in what your ideal project would be, you may not find something that actually is a better fit for you to be able to really develop something, see something to completion, and contribute. So being open to what projects may be out there ongoing already with existing mentors would be really important.
I want to echo that. I think that's key. I mean, our mantra is that this should be partner driven. And so if there are already ongoing projects, great. If not, obviously discussing it with your potential mentors to see what would be helpful and benefit them and the communities that they serve. And the other thing is we always talk about this, it's not original and but humility and going into these experiences, realizing who you are, where you are, your positionality, all of that. And I think that your generation really is quite aware of that. And it's really reassuring to see, because I can tell you my generation was not like that. So it's quite refreshing because I think you're all thinking about those things. I mean, your question obviously demonstrates that.
I would completely agree with everything. I don't think I have anything really out of the box to say other than the basics: humility, realistic expectations, and trying to absorb as much as humanly possible and understand the different perspectives and the complexity of all the challenges and issues that you may be up against, and slowly start to work towards identifying the niche or the area of interest that will keep you engaged and motivated in this line of work.
One other practical piece of advice I would give for a discovery year is that it's not all about the work that you'll be doing there. A lot of it will be about building the relationship. So taking time to get to know the people you'll be working with in the lab or the hospital or wherever in the community you're going to be working in, take them out for a tea, spend time with them, learn about what their lives are like. I think that part of discovery will really serve you as you're thinking about the rest of your global health career.
Depend a lot on traditional that have very different practices and maybe working use this so how do you revert those traditions to the community that we serve, even that was a foundation for the community? When we do disagree with the practice, how do you respectfully provide communication and, rectify that misinformation without denying the knowledge of the different practices?
Hey. First of all, let's ask ourselves why we disagree with those practices. On my first day of medical school, I was told that 50% of what I'm going to learn is going to turn out to be untrue, false. So I would ask myself that question. Why is it that I disagree? And who said that the reason that I think option B is better than option A is in fact true. I think that's the most important pillar. Why don't I just stop there and see what other people have to say?
Yeah, I would agree with that. And I would also say that whenever I'm in that situation, whether it's here or elsewhere, because it happens here all the time, right? In Santa Monica, my patients go to lots of different clinics and they get these IVs with all kinds of things in them. And I have no idea what they're getting. But what I would do in that scenario is actually talk to my colleagues there, because I don't know anything about these treatments. And there's no way for me to say, are these harmful or not. And so I always kind of, ask for support and advice from those around me who know much more about the culture, about the different, alternative modes of treatment. And, and then I don't see them as separate or parallel. I see that you can integrate whatever these different modalities are into the care plan. So that's the way I sort of approach it. But and I think most of us would approach it that way.
When I was doing my field research in Liberia, I lived at a rural training center. And there were Peace Corps volunteers who became my great friends because we'd walk to the local village through the forest with these big torches. And there were also occasionally nurses who would work at Phoebe Hospital. And I got to know one of the nurses because at some ungodly hour in the middle of the night, she banged on my door. Now, this is the human tropics. So you are sweating, you're just in weird dreams, you're on anti-malarials. I opened the door. She said, "This cockroach is in my place." And my very humane answer was, "Send them here, they can join mine." Because there's nothing you could do. I talked to Walter Renegali about the visiting nurses because they had a lot coming from Sweden and Norway because of the Lutheran-funded program. And Walter's comment was, "My biggest challenge is helping them unlearn a lot of things." And I thought that was a great comment, that they would come in all ready to prescribe, tell. And Walter would say they have to listen, understand. And I thought that was such a great comment from his, that yes, they needed these people with clinical experience and training. There weren't enough nurses, especially, 1983 Liberia, but they couldn't just come in, and his term was inject themselves into the healthcare. And so I just thought, what do I need? And he would say, I'd get to know them and think, okay, what do they need to unlearn?
What I would add is there are certain instances where you may find practices that are potentially harmful. And so in those cases, I think it's helpful to empower families to know how to reduce their risk. One example in northern Uganda, when kids are having fevers constantly, they'll often go to a traditional healer who will do a tonsillectomy for them, with often scalpels that are, not sterile. So helping the families understand, well, this may not be the cure for your kid's fever. But two, if you're going to get this done, this is the way to keep your family safe with this. So thinking about how, you could say like, this is an awful option, don't do it, but the family very may well go and do it anyways, because yes, it's what they've been brought up with. And there may be, for, in certain cases, very good reason to do it, but helping give them the information, like sort of what is the Western scientific option telling us for treating this or managing this condition, and how they can really incorporate the traditional practice in a way that's complementary and not dangerous.
So I think I really one of the practices are very important when I'm telling them how this is why but I know it. So when we create this program, I really incorporate that for the next patients feel well that you know. I can chime in just a little bit because we do have a rotation that students do in rural South Africa, through the University of UKZN, and they do a really, really great job with this. So it's something that I can share with you anecdotally what I know from student reflections, but the physicians there in these rural medicine hospitals, family medicines, they do a little bit of everything. They work really closely with the traditional healers, and there's a lot of communication. Not all practices are harmful, but if you have this just kind of black and white way of looking at it, and you have a lot of judgment on those practices, then what ends up happening is the patients are going to share with you. And sometimes they will take some sort of an herb or something that would be really helpful to know when they get to you. And so they keep the lines of communication open, and I think it's a really helpful way to go about things, both for understanding and just we're working together. They have the same goals, right? Like in theory, yeah. I grew up in North Carolina, and I have when we went to the hospital, the city, I did most of the medicine, and I remember a lot of passion. And I know I have friends that are out of medicine, and you look at the connection, and you'll have a good home. Well, you know, when the patient is healthy, and I feel like for me, I want to sure I'm food and I educated myself on the other side.
No, I think that I don't have much expertise at all in this, but there are models where there are, as Dr. Wells is mentioning, sort of partnerships between those who sort of practice more integrative medicine versus not. And I think that it'd be very helpful to kind of look at those models. And, you know, if you're serious about a global health career, if that interests you, kind of seeing where the gaps are, as you're saying. I know that when I was in South Africa about 20 something years ago, working in a pediatric HIV clinic, and I was doing just some research because this was right when antiretrovirals had just started being rolled out in South Africa for children. So this is back in like 2006, if you can imagine. Before that, there weren't really medications available. So I was doing research on that. And so I would see every day, you know, kids come in with their moms, and I would talk to the moms mostly. And a lot of them were seeing traditional healers for their own HIV in the community. And, you know, I kind of listened and learned a little bit about it. And then I would talk to the faculty members. So this was in a township in Pretoria, or outside of Pretoria. But it was like a university sort of hospital. And so the faculty there were completely opposed to traditional medicine, and they would make fun of these mothers, and they would say all these stories and say, you know, for example, the traditional healers will actually charge them more money the lower their CD4 count is. So they would have access to CD4 counts. And I have no idea if that was true, but this was a sort of rhetoric that was happening. And again, this is many, many years ago. And I think things have changed, and there are probably more partnerships now between those who practice different types of medicine, and more integration, I would hope. But I remember being quite struck by that lack of sort of understanding or communication. And it was pretty distressing, I'm sure, for the patients.
Yeah, this is more of sort of a lifestyle question for you all, as a global person, as a physician. So how do you maintain your longitudinal integrated relationship with these partnerships and field? Because I can imagine that those tendencies are compartmentalize it. Are you like here versus super high? And just sort of the way you found helpful in creating that longitudinal.
It's very, very hard. I'm going through that right now, having come back from having lived in Armenia for 2 years, and trying to define how I can continue while now being in a very different model here. But I think it's very also, the answer probably is different based on what you're doing, where you're doing it. So for me, I'm finding for a variety of reasons, for example, that staying up to try to get on these staff meetings that we've established that happen to be at 3 a.m. is not working. It's not working for me personally because I'm not able to function well the day after here. But also, we are not yet at the point where Zoom works in those staff meetings. At the Ministry of Health, still most decisions happen in the hallway outside of the staff meeting, either right before or right after it. And when you're not there for that, just participating via Zoom on the staff meeting is less effective. So for me, I think my working model right now is to, do a minimal amount of that stuff, try to accumulate as much time and ability to physically be in country, and then do short bursts of frequent trips to try to maintain that continuity. But again, my model is being embedded in a Ministry of Health, and that may work. But if someone is a little bit more clinically driven, or in another world where you're on a board of a NGO, it may be a very different model. So I think it's very dependent on what it is that you are involved in, and then also what your day job looks like and how you can blend those. There will be a period of trial and error that goes along with it, and some sacrifices. At the end of the day, there's still nights and after hours that I think everyone on the panel and everyone in global health is putting in above and beyond the 9 to 5 job. But
Well, I'm just the weirdo because since I came back from my PhD in 1981, I've never done domestic work. So my whole life has been attuned to other partners. But when I started, you wrote aerograms. It was really very easy. So all these idiots who created Skype and Zoom and all the rest have ruined my life, because being on projects now, most days, my life is like 5 a.m. to noon. Unfortunately, my wife is an early riser. The cats get me up anyway, but I'm no good in the afternoon, especially if I have an intense project, because it's just meeting after meeting. The upside, of course, is that with these technologies, you feel much more connected with your partners and relationships and working with teams. But for colleagues of mine who are really full-time academics, which I'm not, then I think it's much more difficult for them. Friends of mine, I was talking this morning to a colleague up in the Luskin School who works a lot in Sierra Leone and Liberia. So he has that kind of pressure because he's here, he's teaching full-time and all the rest. Although I was furious with him this morning because he goes, the quarter's almost started. And I said, yeah, just next week. I said, what are you teaching? He goes, oh, I'm sabbatical this quarter. I'm just worried I only have 3 months left. And it took all my restraint not to just slam the door or say something that I had 1 week and he had 3 months. But he has this. He was on early Skype with Sierra Leone. So I think it is something. The other thing is, and I'm sure this goes for all of you, it's not an intellectual distance, it's a personal distance. Because you bond with people, you have relationships with them. And, I can say for myself, my closest friendships generally with people who don't live in Los Angeles, because you've worked on projects and we're so much more bonded. I can't go to a neighbor, even who's a friend, and go, well, I got back from Pakistan last week. Okay. There's no familiarity now amongst yourselves, because you know what it means to go to Niger or to Uganda or Armenia. And you, in your cohort, you have experience. You can say to somebody who's been to Rwanda or Haiti or Malawi, even if it's not the same country, they have that sense of that other and the importance of those relationships. But it's a real challenge.
I think we can take another question. Yeah.
We can just one more and we'll wrap up. All good? Right. I think we can wrap up, and I just wanted to take a moment to thank our MCs for this, Helen and Ope, and also all of our panelists for being part of this today. I think they might be okay with sitting around for a couple more minutes if you have questions. And we will see you all next week.
Hang on, two more things. One, if you can please do, scan the QR code for today's survey, for today's lecture. You all got emails from me earlier this morning. Unfortunately, we had to reschedule our talk with Dr. Chicho Mayfire from tomorrow morning to Wednesday morning at 7 o'clock. So we have three events next week again, one on Monday at 12 here in this room or the next room, one of these two rooms, one on Tuesday morning at 7, and then one on Thursday afternoon with Dr. Michelle Gruner, who is our partner from Ecuador. And one last plug, you guys have also gotten lots of emails from me about the community engagement. Sign up, please sign up if you are interested, because the MS2s are very ready to transition out and would love some new help. But yeah, that's it.
Yeah, just to clarify one thing for next week, I'll send another email, but next meeting, all the events next week, keep in mind that you have to do one or two, for the global version of the deep dive. So you either have to do that Wednesday morning or the Monday at 2. That makes sense? And then it's our first partner conversation on Thursday at noon. And it's gonna be a really, really fun one. It's the only one in person. If you have any questions, let me know.